And this is a classic diagram that has been used to talk about technology transfer and trying to change clinical practice. And it's this continuum from basic biomedical research, which is normally what I do, to clinical research, trying to look at patient groups and building new ideas about what's wrong with them and trying to understand that, to finally getting into clinical practice into a hospital that you will use the general population. And we have these things called valleys of death, which is ideas in basic biomedical research don't get over to clinical research, and an even harder valley of death from clinical research over to clinical practice. So I'm hoping that my first issue about being a basic scientist helps in this first valley of death. And the second one, which is companies are really essential for helping clinical practice. And then hopefully that commercialization side is going to help us actually get it all the way out to the real.
And Steve, can you give us a time frame?
This time frame?
Yeah.
Normal time frame, 20 years. And yeah, so it takes a long, long time for some of these simple ideas, sometimes not even more. So trying to speed this up is a big, big challenge, and so that's certainly part of the value of the commercialization is to, can we speed this process up? So, assessment. Assessment drives healthcare. Here we have hockey. Does he have a concussion or not? We have drugs, new therapeutic interventions. Do they work or not? And if you have, say, a stroke and you have weakness, is it really the problem that stroke caused, or is there a whole pile of other problems that the brain no longer processes information? Is that really the problem? All those questions are driven by clinical assessment. Okay, so how do we assess brain function? Well, we do this. 0, 1, or 2. If you can do it properly, you get a 2. If you can't do it at all, you get a 0. And somewhere in between, you get a 1. That's state of the art for function of the brain. It's subjective, because I'm going to just look at you to see how you did. It's got a course scale. And it's got a course scale so that all the clinicians can score it the exact same way each time. Because you want to make sure you get a 1, it's a 1. But that course makes it really hard to show that you actually improved from 0 to a 1 or a 1 to a 2. And you have floor and ceiling effects. And that means that you might get a 2, a perfect score, but maybe you're not quite doing it right. There's clearly something wrong. But based on the metric, you get all the points. Or you could get a 0, but there's clearly a difference between 2 patients. Some are more 0 than another. And they're time consuming. So that's only one test. And if you try to cover a whole pile of different brain processes, it can take a long, long time. And so if you get into, when I talk to my clinical colleagues, they just don't assess everything because there's just not enough time. It delays treatment. So, what we do, and what I've been doing to give you a bit of history to try to solve this problem and look at this, is looking at robots. Now, my basic research, what I do during my day job, is I use robots and I'm trying to study circuits just like Dr. Munoz, except my circuit is to do with the arms. How do you move your arms in space? And you'll find out that we have lots of areas of the brain, more than he has, and more territory than he has, that are needed to move your arms and legs. And this is one of the robots I've made. There's other robots. There's been lots of robotics designed and used in basic medical research to try to understand this circuit and how the brain works. And so the idea is, if it works really well to understand how the brain normally works, maybe it's useful to understand how the brain isn't working properly. And so what does it do? Well, here's just some simple, useful things about robots. They're inherently objective. This gets rid of the subjectivity of just sitting there looking at how you behave. They're objective tools. You can quantify the movements, and I'll show you more about that. That as you touch and interact with them, they're going to measure how the robot's moving, which tells me how you're moving. I can apply forces. I can move your limb around if I want to, so I can not only measure, I can push you and see how you respond. I can use virtual reality systems. I'll talk to them a bit and integrate and control the visual world at the same time. And I can automate this and make it all just an automated process. So here's the KinArm robot. Everything in science has to have an acronym. So KinArm stands for Kinesiological Instrument for Normal and Altered Reaching Movements. It took about 6 months to come up with that. So it's an exoskeleton robot. The subject's arms go into it. You adjust the size of the robot to the size of the subject's arms. They move in the horizontal plane, so that gives us a certain amount of information. It simplifies whole limb movements to just shoulder and elbow, flexion, extension. We move them into the workspace, and what you're seeing is their hand and virtual targets that are being displayed down in the workspace. So you just have to reach out to these virtual things in the environment. So it's nice and natural. It's not like gaming where you're having to work an avatar. This is you just reach out. And this is just the monitor to see how you behave. This is now some data, and what we're doing is just asking subjects to do visual guided reaching. You put your finger to a light, another light turns on, you just have to move quickly and accurately to the target. And you can see a control subject and a subject with stroke, and you can see clearly there's something different. Healthy controls move, they keep their hands stabilized at the start, they do a nice corrective movement right to the target, it's fairly straight, maybe one little correction, and then you have the other subject, this is the subject with stroke, and you can see large variations in how they move, they don't make it all the way to the target, they have to correct, and there's lots of errors. So we can take all that information, and what we do is break it apart. So this is just the hand movement from the central target as they reach the peripheral target. This is how they move their hand, and what we do is break it apart with math, figure out how accurate were you, how far did you move. This is the hand speed, are you doing little tiny jerky movements to get there? We can count every little bump that you do, and we break it apart and we measure it. So with this is the first work we did. I'm going to talk about the stroke subjects. This is a group that we started at St. Mary's in the Lake Hospital. That was the first system we put in. And we're just using it as a model group of patients because they can have lesions in lots of different parts of the brain, and we wanted to see how many different types of tasks we can develop. So these are all stroke subjects. And with this, you can measure that almost every stroke subject that goes through St. Mary's is going to be impaired compared to what a healthy control subject looks like. The other interesting thing is this last little point down here, which is a lot of subjects, stroke is supposed to be a lesion, say, on this side of the brain, and you have impairments on this side. We can actually find that about half of the subjects with impairments, I guess it's right side strokes, will have impairments with both hands. It's not just one side of the body, there's actually problems on the other side, which is an interesting thing in trying to understand how the brain works in the first place, because it's not this one side versus the other. Here's a subject, this is a pilot data set. And they were doing a central outreaching task. This is a chronic stroke, so they're not in the rehab hospital. They just came in as we were prototyping. And we asked them to reach the targets, and they were really mad because they took their driver's license away. And they can drive. They knew that they had no problems driving. So this is the reaching movements. And what you can see is they have problems moving with their paretic arm. But there's something weird over here. They're not moving. And if you look at just the number of trials completed, you can see there's a whole pile of trials they didn't even attempt a movement to the left. So this is a subject with spatial neglect, is what it's called. And this person can drive. And you're safe to have them drive, as long as your pedestrian comes from the right side. You're fine, they'll see you. But don't come from the left. Because half the time they're not going to see you, and they'll just run over you. So it's a very simple metric, just looking at this reaching task and how you respond, to tell you that they actually have a problem with knowing where things are in the world and responding, and they shouldn't drive. We can do things like trying to quantify improvements. So this is a major challenge for the course rating scale is, can you see improvements? And one of the things when I talk to the physiatrists when they're doing rehab is they spend a lot of time doing rehab, they've assessed them before the rehab, they assess them afterwards, and the clinical scores say they're the exact same. And the patient feels they've gotten better, the physiatrist knows, the PTs all know that they've gotten better, but the course scales don't show that, and that's very depressing, and it's sort of not a very, it makes you not want to keep doing your rehab. So this is an example of a subject, this is a Shidokui Master score. It doesn't matter the score. 7 means you were perfect, so their left arms are good. Right arm is a 3 and 2, so they have a fair amount of impairments. They had this at 4 weeks post-stroke, and then they were reassessed 5 months, and they got the exact same clinical scores. What you can see is if you just do these measurements, you can see the right arm is actually getting better. You can see that movements here were more jagged than here, they're much straighter. These movements are straighter. And you can easily use math just to pull up that to show that, yes, you actually are improving, and it gives you that resolution that you can't get with the existing scores.
So can you transfer that into a score? Can you?
Yes, so we have done a whole pile of ways of doing that. One is, throw a lot of math at it, and we created an analog score from 0 to 8, and we basically score a 0 is someone with severe impairments, 8 is superhuman, and we took all those scores of the people that had exactly the same scores throughout the whole time, and you can see all the lines going upwards towards improvement, except 2 or 3, and they're actually going the wrong way. And so there's the odd one that will go the wrong way. If they finish their rehab, they go home and they sit and watch TV. They can go that way, or you could have other mini strokes that occur. But almost all of them are going up as you would expect. So we can easily grab and try to measure that. So another area we want to get into is somatosensation. So this is using sensory information from your limbs to do motor action. If I try to button my shirt, I don't use vision. I can do it just from afferents from skin and from the muscles to tell me where my arms are. As well as body image. You can shut your eyes and you have an image of where you think your body parts are, and you have that sensation. And that's all done in this chunk. This blue area is the parietal lobe, and that's a large part of it is involved in this understanding where your body is and using it to guide actions. And so we wanted to create a robotic task for this because the clinical scores is move a finger back and forth, and you score it. Can you tell it moving? So the robot's moving the right arms, and the left arm is using it as a readout. So if your arm comes out here, you have to mirror match. If the arm comes in here, the robot's moving it, you have to come in here. And we give a bib to block vision, because if you tell them to shut their eyes, they cheat. So don't do that. So this is how a healthy control, they were supposed to put their hands at the black dots. Blue dots is where they put it. You can see there's a little bit of error in the size of the ellipses, trial by trial, if they try to go to the same spot, how accurate they can be. Here's a stroke subject, huge shift, and you can see large ellipses saying they've got problems in knowing where it is. And this is just some example data. Here's 2 control subjects. It's about the size of errors you would expect with a healthy control. And then different patterns of impairments. You can get shifts in the world, so the whole world's shifted over. You can get these large ellipses. They basically are guessing every trial. Every trial they've got their arm somewhere else for the same arm posture. And we even get some patterns where the world shrinks down, which is interesting because it says that there's very different patterns of these impairments that really we don't know a lot about, and it's one of those basic research sides now trying to understand why is there these different patterns of impairments even where you think your arm is. And for stroke subjects, about half of them have impairments. If you go within 2 weeks of a stroke, actually 70% will have impairments. And an important thing is they actually correlate with your daily activities capabilities. So you have motor problems, it's hard for you to groom yourself, to eat, dress yourself. It turns out these impairments in your body image, knowing where your arms are, also impair your ability to do those tasks. So these things matter, and they're going to matter because you're going to need to learn to rehab this, for example, and yet rehab is normally not focused on this. So this is a whole new area that needs to be addressed on trying to improve these capabilities. This is a control subject. So this is a subject we brought in. We bring in and get a lot of healthy controls. And they were supposed to put their hand at these locations, and these blue dots is where they put it. They passed all the clinical scores, but we looked at this and said, we've never seen a control subject like this. And so we talked to the physician, had a CT scan, and there's actually cerebellar infarct in the tumor. And then what we can do is try to contrast and compare. One of the whole points of this is to get lots of tasks, find out what things you're impaired in, find out what you're not, and to try to create a patient-centered approach to doing healthcare, which is, if this is the pattern, this is the type of rehab you should have, instead of just one fits all. So this is just looking at these stroke subjects, and what we're finding is you can have every possible combinations of impairments in motor and proprioception. You can have a subject that is not impaired in either. You can have subjects that are impaired in both. But you can also find some only with motor problems, some with only sensory problems. And so you can't guess who's going to have a problem in this. And again, they both correlate with your ability to do daily activities. So you need to consider both. And that's sort of what the research is starting to point out for us. So, next thing, clinical exams. Well, like I said, it's a pretty sterile test. You just touch your nose to the clinician's finger, back and forth. This is the real world on the right side. it's complicated. There's lots of things going on. And clinical assessment doesn't really deal with lots of processing of information. That's what we have to do in the real world. So we wanted to make some tasks that would have a little more fun, get at these problems of trying to deal with lots of rapid motor decisions. So your two hands for the subjects are paddles. Balls are falling towards you in the virtual reality, and you just have to punch them away. So the instruction is pretty simple. It starts really simple with just a few balls so that we know that everyone will get a few balls and can contact them. But as time goes on, you're going to find out there's more and more little balls that fall. And it's going to get harder and harder. Each of the balls actually feels like a squash ball. So the robots are giving you this haptic feedback to tell you that you contacted them. And that actually helps you makes you able to perform the task very quickly because you're getting that haptic contact. I hit it, I can go to the next ball. Healthy controls, you'll see, basically they'll use both hands, they're choosing, selecting, moving back and forth. They're hitting most of the balls, although it's getting a little harder, so they're having troubles. And then you have these two very different patterns of stroke subjects. The top one is what I call is a good strategy if you know that one arm doesn't work as well as the other. Basically, you're going to use your left arm because it works, you can use it, and you're going to cover as much workspace as possible. But the hand that's impaired, that's the one that's impacted the most by the stroke, you keep over a small workspace, you keep it off to the side. And that's a good strategy. This is a bad strategy. Has anyone noticed something wrong down here? Just no, every ball on the left is just, yeah, go ahead.
They're both in a small area?
Yeah. This is the impaired arm, they're stuck in the middle of the workspace. Their good arm, they jabbed over here and can only hit a few balls, and they just completely just ignored that side of the workspace. This is again what's called spatial neglect. So this is a impairment where they tend to not attend to anything on the left side of the workspace, and it's pretty obvious. This is what's going on with this patient. So we can take these, make little pretty diagrams so you can visualize it. This is the 10 spots the balls fall down. This is when it's easy, and this is when it's really hard. And you can just see a healthy control, blue hands, left hand hit it, red is the right hand. When it gets really hard, the balls are coming fast. A good strategy is people always start to give up on the outsides because they just can't get over there. So that's just a good strategy. Here's the stroke subject. You can see the asymmetry. This is actually a right-handed subject. That's why they're a little shifted to the left. This is a stroke subject, a lot more misses, and then here's our spatial neglect. And they actually did go after some balls early on, but as the task got more engaged, they actually got sucked over even more off to the side, making it active inattention. It's even worse when they're trying to re-engage in the task. Then we try to go into more complicated things. And the idea is we can get their arms going, and now what we want to do is cognitive processing. So at the beginning, it showed two objects that you had to hit. One was a tall triangle, and then the other, I believe, was a circle, yes. And you have to hit those two objects, and you have to avoid everything else. So we have both arms working away trying to do motor skills, but now you have to attend foveate, which Dr. Munoz talked about, decide is that the right object? If it is, then I have to hit it and go after it. If it's not, then I can't hit it because you actually aren't allowed to hit those others. That's a penalty. So now you get this going, and what you're going to find out is that they're doing about 10 decisions in a second that you've got to process. And the idea is to push and stress the brain to find out when it fails. And I sort of used this task where I came up with it back looking at traumatic brain injuries and going after concussion because it's a group where if they have to process and get it, you slow down. The idea was to try to really push the sensory motor and cognitive systems all at once to see when does it start to fail. We can get into other fun tasks. The whole point is to make tasks that are fun. So here's a ball on a bar. So it's to go after brain circuits where you have to make the two hands work together. So you have a virtual bar that's connected together. You have a ball on top. You have to hold it like a tray. And now you have to move in the environment. If you don't balance the tray, then the ball will fall off. And so what you have to do is handle not only moving your hands, but they got to work together properly to perform behavioral tasks. So this is just looking at a healthy control subject at the top and a subject with stroke as they're having troubles in trying to put those two hands together to do a behavior. I'm just going to show is to get at other aspects. So I talked about proprioception. Well, we also use afferent information so we can do motor corrections. If we get bumped or perturbed, we have to correct those. So this is a very simple task. You're sitting at a target, step function comes on, you get knocked, the robot pushes you away a bit, and you just have to counter that perturbation as they knock you. Healthy controls, it's really fast. In fact, your muscles turn on at about 60 milliseconds to give you a nice corrective response. Very quick, and you'll be back in a few hundred milliseconds. The stroke subjects just can't do that fast, rapid on, turning on to correct for these things. So again, just visually you can see that. And from the next step, and this is something getting back to this theme of trying to get through the second valley of death, we've been doing this in clinical stroke subjects, but the hard part is trying to automate this. It takes a lot of math. You have to have a lot of programming skills to run these robots, and you have to do a lot of programming. What we've tried to do is automate everything. Make it so anyone can use these robots for whatever project you're interested in. So we take all these different tasks, we push through the analysis of the data, and we automatically create a report. So now we can have subjects show up, press a button, they run a task, we press a second button, out comes a report that will tell them how they performed and whether they are impaired or not compared to healthy subjects. And in trying to do that, we compare to lots and lots of healthy subjects. So this is a key thing, and Dr. Munoz brought that up. This is healthy performance for reaction time. If the light goes on, how fast does it take for you to respond? We take kids all the way down to 5 to 18, and then 20 to 80. And as Dr. Munoz mentioned, you're the best when you're about 18 and early 20s. You get faster till then, and then unfortunately, you go further. And so we created this way of looking at tasks. I've tried to give you a few, but the idea is to have lots of different brain functions be assessed. So we have all these different tasks. Some tasks are looking at sensory processing, some are your motor skills, and other tasks are focusing on what your cognitive capabilities. And the idea is all these tasks are fully automated. All the studies we're now running at the present time actually go through this full set of 10 different tasks to try to cover a broad range of domains. And we're now there's ongoing projects in all of these different diseases to try to see how these robots might be of use. We're getting into ALS, cardiac arrest. You mentioned sepsis for infections, so we're getting a group through with some intensivists. Concussion, but anyways, a large number of different groups to see how this technology may be of use to identify their specific patterns of impairments. Now, I talked about robots. Dr. Munoz talked about eye tracking, and what I sort of envision is actually both of those technologies are going to be needed. We're in fact integrating eye tracking in with our whole robotic technology, so we can see how your eyes are moving when you do these tasks. We'll get into probably whole body measurements using technologies motion capture, and all these technologies give us bits of information about the sensory, motor, and cognitive. So our hope is that hopefully in the next 10 years, 5 to 10 years, we actually have all of these different technologies lined up, organized. You can go to a hospital, you have a problem, it's like a blood test. You check off, clinician checks off, you go off and get assessed, and you come back and the report shows up to the clinician. And our goal is to try to do the same thing with all these technologies we've done for basic research to actually turn into real clinical